So I don't have any conflicts related to this particular topic. So distal femur fractures, I think, throughout my career have been a relatively non-controversial injury. I think actually we're a little more controversial or tricky now than they used to be, just because we have more implant options to choose from. But the fractures are easy to understand. They're easy to image. There's basically the anterior approach that we use or some variation thereof. The treatment principles for these fractures are things we all learned, as interns, or our first fracture course, restoring the articular surface, mechanical access to the limb, stable fixation, and those things. And although we know that a lot of the injuries we talk about occur in typically intoxicated young men and typically osteoporotic older individuals, for these distal femur fractures, this recent paper really highlights that the relative risk dramatically increases when you get to be, age 60, now my age and older. And so the consideration of how you treat these fractures in the elderly patient certainly is relevant. So there's basically these two treatment options when it comes to fixation: some sort of nailing, plating, or, as more and more people are now talking about, actually combining the two, which never occurred to me until I saw other people doing that. But we'll talk about that a little bit later in the talk. But when you really look at all the literature, I think the data, and we talked about this a little bit before, shows that, and this is plate fixation, but really any type of internal fixation, so plating or nailing, works well for virtually all fracture patterns, or can be adapted to all fracture patterns, and works well even the elderly patient. And as I think we said yesterday, the complications are a little bit different. You tend to have higher non-unions with plate fixation, but more malunions with nail fixation. But in terms of overall complications, overall functional results, it's really hard to really discern much difference. So and these are just examples of some recent papers published documenting, as I just said, good or quite reasonable functional outcomes and manageable complications with internal fixation of these fractures. This is a paper that just came across my email a couple of days ago that I thought was obviously relevant to this talk, and this was done at the group in Maryland, a very well-respected, well-known group, and they took 68 elderly patients with distal femoral fractures. Half had native fractures and half were periprosthetic fractures, and they all had at least a year follow-up, and they all had WOMAC scores, which in my hospital kind of gets calculated automatically as well. There's Charleston comorbidity indices and these other things. So 91% of these fractures, patients with these fractures, had good to excellent WOMAC scores at their greater than 1 year follow-up. When you really get into the details of the outcomes, the fracture patients tend to have more stiffness than did the total knee patients, but the WOMAC scores were the same as you get with a primary total knee in someone with knee arthritis in terms of the overall functional WOMAC score. Now, in the bold type there in the bottom, it's interesting to note that nearly a third of the fracture patients required some sort of reoperation, but 80% of those were for just prominent hardware that was removed, typically interlocking screws or screws of some sort, and about half of them actually were for non-unions, likely related to plate fixation. So that remains an issue, is the non-unions, just like it is in young patients. But interestingly, even in the subgroup of patients that had reoperations, their functional outcome was really quite good when all was said and done. So again, attesting to the value of internal fixation in these older patients. So early on in my career, the main issue with fixing distal femur fractures, we didn't really use retrograde nails in those days, and didn't have nails for this type of this common unit of a fracture, but it was really coronal plane instability. And the workhorse implant at Hennepin, early and mid-1990s was the dynamic condylar screw, as you see an example of here, and that gave you the coronal plane instability. But when we really had comminuted intra-articular sort of C2 and C3 fractures, and we tended to use buttress plates, not locking plates, as before they were available, just buttress plates. And this was a case that I remember even now, where residents and I had finished. This patient had a distal tibia, I think a mid-shaft tibia. You can see a bit of the proximal tibia, but this comminuted distal femur. And we had everything in an X fix and came back to the OR for stabilizing the femur and used a long spanning, sort of bridging buttress plate. But when we were done, the knee still had varus valgus instability, and the resident was like, the MCL must be torn. And I said, let's get the C-arm, and the whole condylar mass was just toggling on the plate. And so my solution in that case was we just kept the fixator on for a few weeks afterwards and until there was some callus. I never really found out how this patient did because went back to prison. But this was kind of how we handled this problem. So that's been solved. These locking plates, that came out in the later 1990s. We talked about the list plate a bit yesterday. This is just another example of a locking condylar plate, and these kind of indirect reduction techniques worked really well at solving that problem, but they gave us the new problem instead, which is this issue with fracture healing that we never really had in the early parts of my practice, and now we face it now. So this is a paper from 2010 talking about healing complications and delayed unions, non-unions, and distal femur fractures. And this also occurs in the elderly, so you have to pay attention to these principles. So now we talk a lot about balanced fixation, working length. There were techniques that have been developed to try to make the fixation more flexible. 10 years ago, I think it was, we talked a lot about this far cortical locking where you would over-drill or had a system actually designed to have no fixation in the near cortex and the screw only purchased to the far cortex. And I don't know anyone that does that anymore, but we now have plates that are coming on the market that have an area in the middle that kind of is designed to be a little bit more flexible. So these sort of mechanically biphasic plates. Titanium plates have a little different modulus, so better modulus of elasticity, and a lot of systems come in titanium as well as stainless steel. So all this has come up as a response to this healing issue with these stiffer locking plates. This is an interesting paper. You can actually look at a rigidity score, obviously more of a research tool, but you can kind of grade how rigid a construct is by looking at how many screws there are, where they are, how close to the fracture they are, all those things. And if you calculate a rigidity score and evaluate a series of x-rays, you'll see that the non-unions really correlate with how rigid the fixation is. So just an interesting paper. So when you take care of these fractures, this is a fracture that healed, but that, there's a reasonable working length, but there's still that screw in the lowest screw in the diaphyseal segment, maybe a little close to the fracture. And so you think about these things when you're looking at the x-ray, and these are the constructs that you typically see. This area where there's no fixation. This is the comminuted zone. This is the area that Jeff Mast, whose name came up earlier, and others proposed, leaving alone, not exposing submuscular plating, not trying to put hardware into those comminuted segments of bone, and you can see the healing that occurs. So this is really the way we treat these injuries in all patients, but are just as important in the elderly. It's very important in older patients, just like it is in hip fractures, to get them mobilized. They don't tolerate immobilization very well. They have functional expectations that remain quite high. I've been passed by people like that when I used to do triathlons and road races. So the question of weight bearing comes up. What can we do to allow these patients maximal weight bearing? So this is a paper that I showed a little bit earlier from published in the British JBJS, a Bone and Joint Journal, that these kind of current distal femoral locking plates can be safely used and even when patients are allowed full unrestricted weight bearing immediately after fixation. And there's the concept that patients probably don't truly fully weight bear right away. But the point is you don't have to restrict them. And that's important in the elderly. Now, this is a concept I referred to earlier, and this is one of the ways that surgeons are changing fixation to really allow immediate weight bearing in these older patients. This plate and nail construct, and this is really popularized by Liparachi and Yoon in New Jersey, and we've adapted it at our center for some of these elderly patients, and it's useful in periprosthetic fractures. It can be used in native fractures as well. But it was really originally done for the management of non-unions, where this sort of what seems like maximally invasive approach perhaps made more sense, but we now know it has a role in acute fracture fixation as well, and is more and more commonly done at our center. When it was first reported about 5 years ago, Liparachi and Yoon published some small case series, and they made a big deal out of linking the two together. So they would put reduce the fracture, do the retrograde nail first, and then apply the plate, and they would engage the interlocking holes in the nail through the plate. And that's an elegant thing to do. It makes for nice x-rays, but I don't think you need to spend too much time doing that. And in fact, Carolyn and group at Cedars, I think, published a paper showing that biomechanically it didn't really seem to do anything. But I think the overall concept does make sense. When you put the nail in, you move the weight-bearing axis more to the axis of the femur. There's less stress on the hardware. The construct is more biomechanically sound, and the combined benefit gives you added stability with the lateral plates. But again, the linked concept I don't think is quite so important. You can protect the whole femur, which we've talked about as being important in the geriatric patient, because even at the tip of the nail, you've got a little stress riser up at the top. And here, They show how you can put screws even into the femoral neck and head, which really does span the entire femur. And there's some good technique articles you can review for if you're not familiar with the technique. It's kind of the stepwise approach as to how you do that. So if we're talking about geriatric patients, I have to also mention arthroplasty. It's rarely needed late. Just like in the plateau, you don't see a lot of injuries that go into post-traumatic arthritis. But is there a role immediately? And the answer is obviously yes. And perhaps with an immediate arthroplasty, you can mobilize these patients more quickly and perhaps have fewer reoperations, just like in the proximal femur. And that does seem to be suggested by the literature. This is a paper published this year looking at the Part 2 oral examination case list database, which kind of is an interesting way to see what recently typically fellowship-trained surgeons are doing and how their practices are evolving. So between 2003 and 2021, there was sort of a linear increase in the proportion of distal femoral fractures that were treated with immediate arthroplasty, and small increases, but definite trend over a 20-year period. And as you might expect, it was much greater adoption by board examinees who had done arthroplasty training. So that sort of makes sense, I guess. But there are instances where acute arthroplasty is the best option. Obviously, you don't have to worry so much about the articular surface because you're going to resurface it. You can correct alignment, and there's varying degrees of constraints you can use depending on the situation. Stems are available that can bypass the injured metaphyseal regions, and you should end up with a construct that will allow the patient to immediately weight bear. Just like in the proximal femur, you basically take the fracture out of the equation so these patients can be mobilized. And this is the first DFR that I did in a patient who was in his early 90s, still played golf. This was actually a type 3A open fracture, as well as so there is some bone loss there. And at first we just treated him like a trauma patient. We washed him out, put him in an X-fix. He was in the ICU for a few days. I fixed the condyles while we did the initial IND, thinking that that would be helpful if we couldn't get to the articular reduction for a period of time. But he recovered really fairly quickly, and after a long discussion about options, went ahead and did this. And I only saw him in clinic a couple times, and the second time was at about 2 months, and he was fully weight bearing and had been back playing golf already. So I don't think I would have achieved that in a 90-year-old with any type of fixation. The downside of this is the cost. And just like in the hip, if you do an immediate hip arthroplasty, that's very expensive. But I think the literature does show these patients have shorter hospital stays. They have less need for post-acute care. They have fewer complications that need fewer reoperations. And so I think the data is suggesting that the total cost of care, maybe in the first couple of years total, may not be all that much different. But there is some suggestion that mobility in particular is more rapid when you do a immediate arthroplasty, which makes sense. It's actually not that hard of an operation to do, but the components are not readily available, like a total hip component may be at a hospital, and they are, I think, very, very expensive. So this is my summary of the literature, which I essentially have already mentioned. So I think that's what I had to tell you about, and look forward to any questions later. Thanks.